Mayo Clinic presents
Emergency Medicine Grand Rounds.
Hello, everyone, and welcome to the middle of June 2025 to the Always On EM podcast Grand Rounds edition. This is Venkatesh Bellamkonda, but essentially, everyone calls me Venk, like vancomycin. This is an incredibly important show today. When Alex Finch, the best co-host in all of medical podcasting, by the way, when he and I set out on this journey, the United States was in a very different place. Arguably, it was no less chaotic than it is today. The future was no less uncertain. Many people were living with a similar degree of fear and anxiety. This show began in the beginning of the COVID-19 pandemic as a way to channel our energy into something positive for a society of healthcare professionals and a society in general. The emergency department lives to serve the community. We try to help those who need an advocate in healthcare, the unhoused, those with addictions, those without access to care, those who do not know how to care for themselves, and sometimes those who are just cold and hungry and have nowhere else to go. We must learn about human trafficking and learn about child emotional abuse and neglect. We must learn about so many societal aspects that are more than antigens and splenic lacerations, more than suturing techniques and electrocardiograms. As I am preparing this show for you, the U.S. is re-examining itself from the people to the highest levels of leadership and trying to figure out our identity again in politics, in interpersonal relationships, in our practice of science, and of course in medicine. Certainly, vaccines, health finance, health literacy, access to care, and so many issues are burning platforms, and they all fall into the overarching theme of health justice. By this, I mean the pursuit of fairness and equity in healthcare. Do all people actually receive fair and just treatment by our healthcare system? Do all people feel that they receive fair and just treatment by our healthcare system? I recall reading that the tennis legend, greatest of all time candidate, Serena Williams, felt that her feeling of dyspnea after having a C-section was a recurrent pulmonary embolus, and yet her healthcare team did not initially believe her. At least that was her experience. She described a feeling that she had to advocate strongly for herself to be able to get proper diagnostic testing and eventually anticoagulation. Was this because she was a woman? Because she was black? Because she was a celebrity? Something else? In this show, Dr. Taylor Christian, chief resident at Mayo Clinic and soon to be amazing alumnus of our residency program, examines a portion of the history of racism within medicine, particularly focusing on Black history within medicine. And we should all listen carefully so that we can learn from our past and hope to do better in the future. With a formal introduction of this amazing soon-to-be graduate, Dr. Christy Colbinson.
I find these introductions really difficult, I'll be honest. I think it's even harder for Dr. Christian because it'd be easy for me to just highlight her CV and talk about her productivity and research and quality and the fact that she's great clinically, or the concept that she's been acknowledged for her leadership, not just with like Senegal Health and a liaison of DEI, or the fact that you guys all look to her as a leader as you selected her chief resident. But I don't think that's what's really special about Taylor. I specifically remember ending my interview with you, and I thought, wow, like what I saw, and I just hoped we were able to recruit you, because what I saw was an articulate, intelligent, hardworking, resilient, proven leader, and the potential just exuded from you. And as I think over the last 3 years, there's been a lot of those wow moments, but what I admire the most about you is the fact that you have very intentionally chosen every day to just show up and bring your best for your patients and for those who work around. And I have so much admiration for that. You have such an internal locus that you never make excuses. You work hard, you try to get better every day, and you combine it with great medical knowledge and a great bedside manner. And then I reflect on the fact that you're doing all of that as the mother of 2 really young kids. And I think of the sleepless nights, the stressful moments, the physical and emotional fatigue, and it was never once reflected in your performance, your administrative follow-through, or your attitude. And that is so respectable. I think in a full 360 moment, we just had Peds Mock Code, and I asked Taylor to lead, not recognizing that she was, of course, closing Peds. And I get it. It's a really stressful situation where you're just expected to step up and perform in front of your colleagues. So on probably like 3.5 hours of sleep, didn't complain, didn't tell me about it. You just stepped to the foot of the bed and showed the physician leader I had seen in that interview. And it was just such a powerful moment. So thank you for everything you do for our residency, and we really look forward to having the opportunity to learn from you today. Thank you.
A medical profession that remains unaware of the racist legacy of American medicine cannot even begin to pursue meaningful reform. In today's political climate, this topic is highly relevant because systemic racism continues to shape healthcare disparities, affect patient outcomes, medical trust, and the ethical responsibility of physicians. We have a duty not only to treat, but to recognize and address the inequities that impact our patients and our colleagues. So first, let's define medical racism. Medical racism manifests as both structural and interpersonal racism within the healthcare system, leading to disparities and inequity in treatments, diagnoses, and outcomes. There are several medical algorithms that adjust risk scores based on race, often leading to undertreatment of Black patients in areas like kidney disease, cardiology, and transplant eligibility. There's a false belief that Black patients have a higher pain tolerance that has been perpetuated over time. It is well known that Black women are 2 to 3 times more likely to die from pregnancy-related complications. Experimentation without consent has fostered a well-seated distrust of healthcare in African-American communities. And still today, despite the overwhelming evidence, Black patients are offered fewer advanced or surgical interventions than white counterparts when presented with the same indications and adjusting for variables such as education and income. In the next sections, we will examine historical roots and evolution while acknowledging key examples of medical abuse and bias. The injustices of the past are not just history. They manifest in the present. Today's disparities are not accidental. They are the result of historical injustices, biased medical practices, and systemic inequities that persist. We will start by exploring the history of medical racism in the 18th to 19th century. During the 18th to 19th century, the majority of Black individuals were enslaved and suffered in egregious conditions that focused on dehumanization. Medical care provided was mainly aimed at maintaining a labor force for productivity of slaves. This era was characterized by the birth of pseudoscientific beliefs, medical exploitation, and forced experimentation in the guise of scientific advancement. Black people were used for surgeries, often with no anesthesia, anatomical dissections, and procedural or surgical practice to perfect techniques. The bodies of enslaved Blacks were stolen from the cemeteries and sold to medical schools and hospitals for dissection. This reinforced the idea that Black lives were of lesser value and exploitation was beneficial if it were for scientific purposes. Pseudoscience during this time focused on polygenism and biological inferiority myths. Polygenism is the belief that different races were separate species. This was used to support dehumanization of people of African descent. Black people were believed to not be fully human and therefore classified as property. Samuel Cartwright and Josiah Knott were medical professions during the 19th century who also promoted the idea that Black people had physical and mental deficiencies that made them better suited for hard labor and a subservient role in society. J. Marion Sims is known as the father of modern gynecology. He's known for surgery advancements aimed at repairing vesicovaginal fistulas. Pictured here are Anarcha, Lucy, and Betsy. Sims conducted these surgeries without the consent of these individuals and without any anesthesia. He believed that Black people didn't feel pain or had a higher pain tolerance and therefore didn't require any anesthesia. These women were enslaved and therefore they were considered property, therefore consent was not necessarily needed. Anarcha underwent many painful procedures, but her name and contributions, like many other enslaved African Americans, were not mentioned when we discussed the history of advancements, specifically in the case of gynecology. As we advance through the timeline of medical racism, the 20th century was a pivotal time for medicine where racism evolved in more insidious and institutionalized ways. We will cover several key topics within this era. This time period is characterized by medical practices specifically targeting Black people, emphasis on systemic neglect, and continuation of experimentation without consent. The specific examples listed are likely well known to most of you. So what is scientific racism? This is the misuse of science and medicine to support the idea of racial hierarchy and inferiority. This was used to frame racial disparities as genetic or biological rather than the result of structural racism and social inequities. There is also genetic determinism. This is research that frames specific diseases as inherently more common in Black individuals and ignoring the impact of system stress or social determinants of health. Slavery was abolished in 1865 with the ratification of the 13th Amendment, though many slaves weren't freed until long after this. And despite the abolition of slavery, segregation continued. Black patients were often forced to hospitals specifically for Blacks. They were underfunded, overcrowded, and lacked access to the same quality of care available to white patients. Black people were denied admission to white hospitals or forced to use segregated wings. Black doctors and medical professionals were often denied access to medical training or research opportunities and faced barriers to practicing medicine in white hospitals. Black patients also initially sought out white doctors because they were thought to be more knowledgeable or better trained based on the resources they had available. The division of medical services by race contributed to disparities in health outcomes that have continued into the 21st century, including unequal access to healthcare, poorer quality of care, and worse health outcomes overall for Black patients. The 20th century is also marked by health disparities that have their roots in historical practices of discrimination and exploitation. Black women in the U.S. continue to experience maternal mortality rates 2 to 3 times higher than white women, a disparity that can be traced back to a history of neglect and mistreatment during pregnancy and childbirth. The infant mortality rate for Black infants has historically been higher than that of white infants, partially due to disparities in prenatal care, access to resources, and systemic racism in the healthcare system. The longstanding myth that Black people have a higher pain tolerance continues to influence treatment decisions in the emergency department, leading to undertreatment of pain and delays in care for Black patients. Diseases like hypertension, diabetes, and asthma disproportionately affect Black populations due to a combination of social determinants of health, structural racism, and poor access to medical care. Has anybody ever heard of Henrietta Lacks? So she is actually one of my favorite people in kind of medical history, especially involving African Americans. Henrietta Lacks was a Black woman whose cells became one of the most important tools in medical research. Her story remains one of medical exploitation, ethical violation, and racial injustice. Henrietta grew up in poverty in Roanoke, Virginia. She eventually moved to Baltimore, Maryland, where she sought medical treatment at Johns Hopkins in 1951. This was one of the few hospitals in the area that treated Black patients. She was 31 years old and experiencing abnormal vaginal bleeding. A tumor was found on her cervix, and she was diagnosed with cervical cancer. She underwent a biopsy that involved taking cells from her tumor without her knowledge. She was never informed that these cells were taken from her tumor or that they would be used for medical research. Her physician was George Gay, who had been working on growing human cells in culture. Her cells became the first immortal cell line. They are known today as HeLa cells, and they have played a pivotal role in medical research and development of numerous life-saving treatments. Unfortunately, many people aren't aware of the backstory that involves the exploitation of Henrietta. Her cells went on to play a pivotal role in development of the polio vaccine, cancer research, gene mapping, and medical testing of new drugs. Henrietta's cells exist in many laboratories around the world. Despite the obvious popularity of her cells, Henrietta's contributions were never acknowledged during her lifetime, and her family also was never informed or compensated. Themes that reverberate through history in the case of Henrietta Lacks are the lack of informed consent, medical experimentation and exploitation, and racial disparities. Despite the significant contribution of Henrietta Lacks, her family was left in poverty without access to the same medical advancements that were made possible by the HeLa cells. We'll next move on to the Tuskegee syphilis study. Have you all heard of this by chance? So this is probably one of the more popular cases of medical exploitation that is pretty well known. So the Tuskegee syphilis study spanned across 40 years between 1932 and 1972. It involved 600 African-American men. It is, like I mentioned, one of the more commonly mentioned cases of exploitation that explain the mistrust in Black communities. The study was conducted by the U.S. Public Health Service. There were a group of 600 Black men. 399 of those men were diagnosed with syphilis and intentionally denied treatment. The scientists wanted to observe the progression of the disease when it was left untreated. So key points of this study: informed consent was never obtained from the participants. They were misled into believing they were receiving treatment for bad blood, whatever that was. Penicillin became standard treatment in the 1940s, which was only about 8 years into this study. The participants continued to be denied penicillin, leading to unnecessary suffering exponential spread of disease and death. The study only stopped in 1972 after a whistleblower revealed the underlying unethical practices. I want to emphasize that this study ended only 53 years ago. So this particular paper, More Than Tuskegee, Understanding Mistrust About Research Participation, this paper was published in the Journal of Healthcare for the Poor and Underserved in August of 2010. It goes beyond the Tuskegee syphilis study to acknowledge and address the lasting impacts of mistrust within the African American community and how historical contributions have shaped this framework. So the eugenics movement gained popularity in the early 20th century. It sought to improve genetic quality of the human population through selective breeding. This movement targeted Black, Indigenous, and immigrant populations as genetically inferior. Black women, along with other marginalized groups, were forced into sterilization under the pretext of improving their social and economic outcomes. Eugenics policies promoted the idea that Black people were unfit for motherhood, and policies were enacted to restrict their reproductive rights. This was part of a larger narrative of controlling the reproduction of marginalized communities and creating a pure population. Many doctors and public health officials were involved in the eugenics movement, and it was promoted in medical schools and publications. This led to racial biases being ingrained in medical education and clinical practice, and law as well. So the Virginia Sterilization Act of 1924 exemplifies how medicine and science have been weaponized to control and oppress marginalized communities. This was a law enacted in Virginia to permit forced sterilization of individuals that were deemed unfit to reproduce. This specifically targeted individuals classified as mentally ill, feeble-minded, or genetically inferior. This disproportionately affected the African American communities, as you can imagine. In 1927, the Buck versus Bell Supreme Court decision upheld the act, with Justice Oliver Wendell Holmes Jr. infamously stating, 3 generations of imbeciles are enough. Between 1924 to 1979, more than 8,000 Virginians were forcibly sterilized under this act. The American eugenics practices were frequently cited in Nazi eugenics programs as inspiration for their pure population and methods to obtain that. It was only 23 years ago, in 2002, that Virginia issued a formal apology, and only 10 years ago that surviving victims were offered compensation for reparations. The civil rights movement in the 1960s brought attention to racial injustice. Activists and medical professionals began to push for systemic reforms to ensure equal access to health care. The Hill-Burton Act of 1946 was legislation that provided federal funds for the construction of hospitals, but also required that these hospitals provide non-discriminatory access to care. However, the act was often circumvented, as most things were during that time period, and segregation persisted. There was also a medical civil rights movement that took place during this time period. Organizations like the National Medical Association and Association of Black Women Physicians began advocating for equal access to medical education, advancement for Black doctors, and policies to address health disparities. So moving on to our next objective, let's recognize long-term impact on health disparities. The 20th century was both a time of progress and profound injustice in healthcare. Despite significant medical advancements, the institutionalization of racial disparities continue to affect Black patients, and the legacy of these historical injustices still shape the healthcare system today. The Tuskegee syphilis study and medical experimentation without consent created lasting mistrust among Black communities. The eugenics movement and forced sterilizations targeted Black women and undermined their reproductive rights. Segregation in hospitals and healthcare systems contributed to disparities in access and health outcomes that persist today. The medical exploitation of Black bodies, from Henrietta Lacks to the HeLa cell lines, continues to influence modern debates about ethics in medical research. 1,000 Cuts: Racial and Ethnic Disparities in Emergency Medicine. This paper highlights inequities faced by marginalized communities within the emergency department and how implicit bias, structural inequity, and differential treatment contribute to poor outcomes for minorities. Key findings within this paper include racial and ethnic minority patients experiencing longer wait times in the ER, words are hard, compared to white patients, lower rates of pain medication administration, particularly for conditions that require opiates, and decreased likelihood of receiving advanced imaging such as CT, MRI scans for the same conditions as white patients. Even when pain assessments are conducted at similar rates, Black patients receive pain medication significantly less often than white patients. So how does this affect patient outcomes? Delaying pain treatment can lead to worse clinical outcomes, prolonged suffering, and increased medical mistrust. Underuse of imaging and diagnostic tests can also contribute to misdiagnoses and suboptimal treatment. This paper also discussed the pre-hospital care from data obtained from the Oregon EMS information systems, which covers about 70% of EMS agencies in Oregon. The data showed that Black, Hispanic, and Asian patients were less likely to receive pain assessments and medication from EMS personnel for blunt traumatic injuries. Black patients were found to be at the highest disadvantage, receiving pain medications 32% less often than white patients. This held true when adjusting for factors such as age, sex, insurance status, and location. When we break this down to the structural and systematic causes, implicit bias is kind of at the top of the list. EMS providers may unintentionally minimize the pain of racial and ethnic minority patients. Geographic and resource inequities is another issue. Minority communities have longer EMS response times or fewer advanced life support services available. Different hospital destinations. So this study specifically found that racial and ethnic minorities are more likely to be transported to underfunded safety net hospitals, which may offer fewer resources and lower quality of care. But what is implicit bias? Implicit bias is subconscious rather than deliberate discrimination. It is most likely to impact subjective decisions such as pain management or transport destination in the pre-hospital setting. And what are ways we can combat this? Patients with conditions that have clear treatment protocols, for instance, migraines or fractures, show fewer racial disparities in treatment. One suggestion is to develop standardized treatment algorithms, which overall our department has done a great job for many clinical decisions. Implicit bias training should be done at regular intervals for pre-hospital team members, as well as the emergency department staff. This is another reason that diversity in the workplace is so important. This helps improve cultural competence, which overall allows us to provide more meaningful care to our patients. I encourage each of you to take the Harvard Implicit Association Test, or the IAT for short. I included a little screenshot there. This test specifically measures the strength of associations between concepts, for instance, Black people or gay people, and evaluations such as good or bad, or stereotypes such as athletic or clumsy. So it's a really nice test to kind of find what biases you may have. This study was a multi-center retrospective analysis that analyzed over 4.2 million emergency department visits across multiple centers to examine the prevalence of physical restraint application among different racial and ethnic groups. The results of this study found that Black patients were restrained at a 0.59% rate versus white patients with a restraint rate of 0.46%. After adjusting for variables such as age, sex, and clinical presentation, Black patients had a 1 1/3 times higher rate of being restrained compared to white patients. The racial differences in pediatric emergency department triage scores was actually also kind of surprising to me. This was a retrospective observational study that analyzed data from 550,940 pediatric ER visits. This study found that African American, Hispanic, and American Indian children were more likely to receive lower acuity triage scores compared to white children. After adjusting for potential confounders, African American patients were 89% more likely than white children to receive a lower acuity triage score. This study also considered triage scores, like I mentioned, in Hispanic and American Indian patients, and found that they too are at a disadvantage by receiving lower triage scores than white patients. This suggests a minority pediatric patient may face disparities in the initial assessment of illness severity, which potentially impacts timeliness and quality of care. The above paper discusses disparities in access to kidney transplantation. The focus is on inequities among younger and healthier candidates. Research shows that factors such as race, ethnicity, socioeconomic status, gender, and geographic region significantly impact the likelihood of being waitlisted for a transplant. So they specifically in that paper referenced the study that are also listed here by Hussein et al. They examined young dialysis patients that did not have any medical comorbidities and found that only 30% were waitlisted within a year, with significant disparities based on race, gender, employment status, and access to nephrology care. The document highlights the need for structural interventions and policy change to address these inequities and improve access to kidney transplantation for disadvantaged groups. The analysis included 52,902 patients that were 40 years old or younger who began dialysis between 2005 and 2019. Within 1 year of starting dialysis, 27.6% of those people were placed on the kidney transplant waitlist. After adjusting for various factors, the study found that of the Black patients, there were only 34% or 34% had a lower likelihood of being waitlisted compared to white patients. The author of one of the prior papers used the analogy of death by 1,000 cuts to emphasize how a series of small, seemingly minor disadvantages accumulate over time to create severe health inequities. How can we work together to decrease our own contributions to systemic racism? Unlike explicit discrimination, implicit bias operates subtly. For instance, delayed ambulance response times in minority communities, longer ER wait times for minority patients, less likelihood for receiving pain management or diagnostic testing, lower rated triage scores, increased referrals to underfunded hospitals. Each of these alone seems small, but additively result in significant worse health outcomes that impact entire communities. Medical racism is not just about single instances of discrimination. It's about a pattern of cumulative disadvantages that persist across the stages of emergency care. As many of you are very familiar with, RICH TIES is an acronym of Mayo's values: respect, acknowledging the historical injustices that have shaped mistrust in healthcare and treating every patient with dignity; integrity, committing to unbiased, equitable care; compassion, ensuring that all patients receive patient-centered care; healing, acknowledging and addressing systemic disparities to promote true health equity; teamwork, multidisciplinary collaboration to create standardized protocols to reduce subjectivity in medical decision-making; innovation, data-driven solutions; excellence, striving for the highest standard of care by holding ourselves accountable for eliminating racial and ethnic disparities in our department and serving as leaders in this field; stewardship, using our medical knowledge and resources responsibly to advocate for and serve the most vulnerable patients. As most of us here are very familiar with, the needs of our patients do come first. This is regardless of race or ethnicity. Driven by our values, in 2020, Mayo renewed our focus on fulfilling our vision for who we aspire to be: a place of equity, inclusion, and opportunity for all, including our Black staff and patients for the entire Black community. Today, we continue to focus on fulfilling the vision by fostering a culture of belonging and safety for staff and patients, staying true to our core values and working together with compassion and respect. The Board of Governors made a commitment of $100 million specifically to work on eliminating bias in medicine and science, giving equitable access to Mayo Clinic's knowledge and service to patients, addressing barriers, achieving true belonging among Mayo Clinic staff and students, and reflecting the diversity of our patients and communities among our staff, students, and leaders by ensuring equal employment, educational, and advancement opportunities for all. The Board of the Governors of Education specifically quoted the following when talking about the commitment to end racism. In education, we will strengthen our diversity and inclusion pipeline programs for healthcare professionals. In research, we aspire to foster a diverse community of investigators, ensure our clinical trial accruals accurately reflect the diversity of our patient population. In practice, we strive to recruit and develop clinical leaders who are representative of our broader community and to foster a culture of safety and belonging for all staff, students, and patients. We will leverage our platform and digital strategies to help improve health equity across the nation. We will address conscious and unconscious racism through our organization by extending equal employment opportunities to all and rejecting discrimination. We will invest to make healthcare accessible to all and eliminate healthcare disparities. We will accelerate efforts to identify and create opportunities for all staff to get personally engaged in meaningful community service activities. More about the commitment to end racism can be found online and how to get involved. Here, I would like to discuss a couple ways that racism can manifest to give context on how we can respond. A macroaggression is a larger scale or institutional level discrimination and harms entire communities of people. This is overt racism, as we have discussed, and it's the most easily recognized. In contrast, microaggressions aren't as obvious. A microaggression is much more subtle and often unintentional comments or behaviors that communicate negative or prejudiced attitudes. These seem the most minor, but accumulate over time and cause significant harm. A micro insult is also subtle and often unconscious. They demean a person's identity or heritage. Micro insults convey disrespect and reinforce negative stereotypes. Micro invalidation consists of comments or behaviors that dismiss, negate, or undermine the experiences, feelings, or reality of marginalized individuals. So how do we address racism? So within education, anti-racism training and updated medical curricula. Within research, addressing racial bias in clinical studies and algorithms and reflecting the study population on the community. Representation, promoting diversity in medicine. Community engagement, rebuilding trust with marginalized populations. I'd also like to point out that we have an Office of Patient Experience that collects data to drive improvement in these spaces. The GRIT method was developed to help people address microaggressions in a non-accusatory manner. You first gather your thoughts. Remind yourself not to react with anger and decide if you're in an appropriate time or place to address the perceived microaggression. Restate the comment or ask the commenter to restate the comment. Allow the person to clarify or realize the potential negative impact that their statement may have had. Inquire, dig deeper, and seek clarification. Be non-judgmental. Address the comment or action without making it about the person. Talk it out. Discuss your personal perception and potential impact on others. That's how we grow as a community. The Bennett scale is also known as the Developmental Model of Intercultural Sensitivity, or DMIS for short. It is a framework that describes how people experience and engage with cultural differences, progressing from ethnocentric to ethno-relative perspectives. The 6 stages are divided into these 2 categories. In the ethnocentric stages, there is first denial of differences, which then polarizes to an us versus them as a defense mechanism. The final stage in the ethnocentric stages is minimization of differences and a false sense of cultural sensitivity. Statements such as being colorblind or not seeing color or all lives matter is an example of minimization. Moving on to the ethno-relative stages, there is recognition or acknowledgement of cultural differences in the acceptance stage. This moves to adaptation, where one has developed a high level of intercultural competence. An individual is able to shift perspectives and behaviors in order to interact effectively across different cultures. And the final stage is integration, where an individual fully incorporates multiple cultural identities into their own worldview. So the EDDEI Council, or Diversity, Equity, Inclusion Council, includes 2 members from the residency program leadership team, a resident liaison, a chair, and a co-chair. I linked the website to show how much more information is available about the DEI Council, as well as resources that are linked to help you navigate and advance diversity, equity, and inclusion within our department. I was going to click on the link and scroll through the website, but as you can see, technology is not quite my friend, so we won't click on the link today. So what exactly is the EDDEI Council? It was formed in response to Mayo's commitment to close the door on racism. The goal of the EDDEI Council is to eliminate healthcare disparities and advance a fair and just environment for our patients and employees with respect to historically underprivileged categories of identity. Our goals are to support and encourage Mayo Clinic's values that are outlined in the Rich Ties acronym that we just covered. Continually evaluate current education, practice, patient outcomes, and research systems for bias, and initiate projects, create innovations, and make recommendations for sustained improvement in the diversity, equity, and inclusion of our department. One final resource that I'd like to share is Mayo's Get Real website. This platform was created to allow the sharing of experiences to help build a community that is more informed, supportive, and inclusive. This is not a way to specifically report instances of abuse, however. A trainee mentions how, specifically, people can identify in any of these categories or none of these categories and show up as an ally or just hear stories that people are sharing about their experience within Mayo or within different departments across the health system. A trainee mentions how she was seeing a patient when a surgeon came in and began speaking with the patient directly, initially with no acknowledgement of her presence. He then looks to her and says, "You must be the interpreter." She corrected him and his response was, "Oh." He then continued to talk to the patient and left with no further acknowledgement, remorse, or apology. An African-American person stated hearing comments from co-workers such as a cotton-picking minute, Oriental patient, or crack the whip. They stated, I am constantly offering better things to say when I hear something uncomfortable, but it is becoming tiring. A comment that was added 2 years ago by an African American who was the first Black person to be hired in their department since the creation of that section in the late 90s talks about how they have set records for sales and developed a cult following of patients that adore the healthcare experience provided. Yet their supervisor visibly treats them different and takes any suggestions, questions, or concerns as being difficult. This person has been labeled as having behavior issues. There are so many more instances that will absolutely shock you when you read through the stories that are posted on this website. I will leave you with this last highlight. This one actually almost brought me to tears this morning. Another person expressed their frustration in a comment highlighting the ability to vocalize one's experience and the perception by people who don't identify with marginalized backgrounds. They stated, "You will never truly understand our experience, but all I hope is that you can realize that we are trying to live our lives with the identities we carry with us, and that we are doing the same job as you at the end of the day." To my fellow people that belong to a marginalized community, I just want you to know that you are so strong, so smart, and that you are enough. Things are difficult right now, and I don't want to promise things will get better, but myself and others will continue to fight until we are seen and acknowledged. The fight for racial equity in healthcare continues, and understanding the roots of medical racism is essential for creating a more just and equitable system. So as far as our call to action today, what can we do as healthcare providers? Acknowledge and challenge our implicit biases. Advocate for policy and systemic changes. Promote diversity, equity, and inclusion. Get involved with our emergency department DEI team. Promote community outreach programs that improve trust and promote health literacy. Commit to lifelong learning and accountability of one's actions, and learn how to be an ally. Finally, I want to say a few thank yous. First, thank you to Dr. Sangha for serving as my mentor on this project and for sharing passions in the same space and doing so much important work within our department on these same topics. She couldn't be here today due to travel. Thank you again to Dr. Colvinson for a way too kind introduction, especially after I asked on such short notice. Thank you to all of you for remaining engaged in this presentation and always serving as advocates for our patients and making a safe place for the coworkers. Life's most persistent and urgent question is, what are you doing for others? We cannot fix what we do not confront. And lastly, I'll leave you with a few books that I think will be some good reads and a couple that I have read that are great reads. And happy to take any questions. Yes.
No, fantastic talk. One question I was kind of just hovering in the back of my mind. You mentioned several articles looking at kind of different metrics or things that have been, I guess, measurable to demonstrate like the discrimination or differences in care. Are you aware of any of those metrics related more directly towards like Mayo and how, I guess, we compare to those papers or even national averages?
Yeah, I didn't check specifically if there are any Mayo metrics that have been compared. I'm sure, with all the data departments we have, that these numbers are available, but I don't think anybody's actually gone in to look and compare to see kind of where we fall in these areas. But I think that would be a great project, actually.
Venk, cutting into the recording. Several years ago, Dr. Zach Meisel from the University of Pennsylvania Emergency Department led a multi-center project of which I had the great privilege of being the Mayo Clinic site PI. The primary focus was to see if having access to personalized risk information on opioid addiction would change a patient's desire to have opioids for conditions like back pain and renal colic that frequently resulted in opioid prescriptions. The study was fascinating and worth reading. Yet, to answer this question that was posed in the Q&A, we performed a secondary analysis of our data and published this as well, and it has relevance here. So the question, again, is how does Mayo Clinic do? Are we any different with our biases than everyone else? The article I'm referring to includes several authors, including me and Zach Meisel. The lead author, though, is the amazing and wonderful Dr. Eden Engel Riebitzer, and the article is titled Patient Preference and Risk Assessment in Opioid Prescribing Disparities, a secondary analysis of a randomized clinical trial published in JAMA Network Open in 2021. The study included 1,302 patients with renal colic, musculoskeletal back pain, or neck pain, and included 4 academic medical centers, including Mayo Clinic, across the United States. This secondary analysis looked primarily at if a patient wanted opioids and whether or not they actually received them based on if they were black or white. This was secondary analysis, so it was not the primary focus of the study and the study design, and that brings definite limitations to what we can conclude and what we should take away. So please keep that top of mind as I share what our study found. What did it show? Black patients had lower likelihood than white patients of receiving an opioid prescription in general, with an odds ratio of 0.42. The percent of times that a patient's desire to receive opioids and whether or not they received them, that matching, we called concordant treatment in the study, that percent was the same between white patients, 64%, and black patients, 66%. The interesting thing, however, was when we looked at the discordant group, that is to say, when the patient's desire to receive opioids did not match whether or not they received them. For the 384 black patients where there was discordance, the largest discordant group was patients who preferred to receive opioids but did not receive them at discharge, 30%. 4% of patients did not prefer to receive opioids but still got a prescription at discharge. Among the 454 white patients, 20% preferred to receive opioids but were not provided them at discharge, and 15% did not want them and still got a prescription. So let me recap this. 30% of black patients versus 20% of white patients wanted opioids but did not get them. 4% of black patients, 4%, versus 15% of white patients did not want opioids and still got them. So what do I take away? It is very likely that even us at Mayo Clinic are not immune to the problems of every other human being. We too likely have biases that, if left unchecked and unaddressed, have the potential to affect our patient care, and so we must be constantly working to rise above them. All right, let's get back to the Q&A.
I'd be curious, I always struggle, how do you bring this into educational curriculum? What's a good process of going about this?
Yeah, I think it's a difficult topic in general, just because I think it gets into kind of sticky situations where some people may feel offended on the topic. But I think in just sharing the facts and, there's plenty of research that shows, these situations have directly influenced current problems today. And, I think just not being afraid to state the facts. Yeah, I think it's very interesting topics. And so digging a little deeper to find, what's something we may not know or what's a problem we have within the ER. I was on shift yesterday and one of the consultants mentioned how GFR for Black patients used to be reported as eGFR for a Black patient, and that was one day removed, but there was no circling back of kind of why was it there in the first place or why did we remove it or, no further understanding or digging into the history of issues that come up. So I think just being more vocal in general. And so bringing it into education, I say just do it.
Venk jumping in again. There are a handful of interesting publications that discuss incorporation of racism curricula and anti-racism curricula into medical school and undergraduate education. I've not found anything about how to do it within a residency just yet. There is an article, though, that provided a framework for application into any educational scenario that dovetails on what Dr. Christian is saying. This is an article in the journal Medical Teacher from 2023 titled 12 Tips for Implementing and Teaching Anti-Racism Curriculum in Medical Education, and the lead author is Maya Racic. Hopefully I said that correctly. It's spelled RACIC. I want to quickly cover their 12 tips, and if you'd like to dive deeper into any of them, I encourage you to check out their wonderfully written article. First, raise awareness among leaders, faculty, staff, and students. Second, provide institutional definitions of racism and anti-racism. Third, engage topic experts. Fourth, foster student engagement in the implementation of anti-racism work. Fifth, understand learners' experience and needs. Sixth, Involve students and residents in caring for diverse groups of patients. 7th, use guidelines to develop longitudinal anti-racism curriculum. 8th, blend different methods to advance anti-racism teaching. 9th, develop anti-racism educational materials including diverse identities. 10th, conduct pre-curriculum assessment and post-curriculum evaluation. 11th, use guidelines for formative and summative assessment. 12th, establish metrics to measure progress and improvement in anti-racism work. I think this is a pretty logical and intuitive framework that we could all wrap our heads around to make progress in this space. Okay, heading back into the recording.
Yes.
Thank you for sharing your wisdom with us, Taylor. I don't want to make too hot topic of a question, but with concerning federal changes regarding funding of DEI, how do you see that affecting initiatives at Mayo? Do you feel like it will be impactful in a really hurtful way, or is it kind of just independent of what we do here?
Yeah, I do think it will be impactful in a negative direction. Specifically, the Board of Governors, like I mentioned, contributed or donated $100 million for these specific issues. I'm curious to see where that goes in the next few years or how that policy stays standing is my hope. Yeah, I am concerned of kind of the implications of federal changes, specifically surrounding DEI. I don't think we have yet, as far as released a specific statement.
Do you think representation in medical education is improving at all?
I think it's so specific to regions. I'm hoping that it improves, but I know we've seen a lot of changes kind of pre-COVID, post-COVID. I think even with the current, political administration, I think that's going to make a lot of difference in kind of what the numbers pan to look like. I went to medical school in the South where, I had a class of 165 with about 8% Black people within a community that's primarily Black, so where's the issue? I think our academics or our admissions committee there has done a lot of work to really advance that mission of African Americans into that specific medical school. And I think that needs to kind of be mimicked across all the spaces where we're specifically paying attention to what our class makeups look like and how that will affect not only our learning, but our patients as well, or what that does for, future people going into medicine or, the future patients. So I think it just needs to be more of an intentional effort. We'll see.
Thank you.
Thank you.
Every time I hear or read about the history of racism, not only in America but in the world, I get pretty angry about humanity, but in a way I get hope because it is a lot better than it was 20 years ago, 50 years ago, 100 years ago. One of the things that we're talking about, how to bring it to education, and you mentioned implicit bias, that we all have it, even though we try, I'm not racist. There are implicit bias historically from that we all know. You mentioned a website for evaluation of implicit bias.
Yes.
Question is, can you send it to us? In an
Oh, yes, I can.
Yes. And do you think that some type of evaluation of implicit bias during our education for residency would be a good alternative trying to go towards?
I do. I really do. I think the first time I heard about the Harvard Implicit Association test was maybe 3 or 4 years ago. And, I myself thinking I have no biases and maybe not understanding what exactly a bias was. I did take you can have there's so many different tests where you can look at, bias on skin color or male versus female or kind of whatever the different parameters are to see kind of where your biases lie. And honestly, we all have biases. I think it's acknowledging those, being aware of those, and then actively looking at how that affects the decisions you make is what's most important. But I do agree, taking the implicit association test as a trainee, I think it does really reflect into the clinical workspace where you're being more mindful of decisions you're making. I've had patients where, in one room, I'm handing out opiates like candy, and I go to the next room and I'm like, okay, why? What triggered in me to be a little more mindful of, or a little less aggressive with my pain management in this room? So I think, knowing your biases, and then when you get in those situations, being able to recognize I must have a bias going on is what's important.
If you want to just send it to me, I'll try to build time into some of our full classroom. That way everybody can do it, because it takes quite a while to take the test.
It does.
Yeah, it's like a good half.
It's a lot of questions.
Yeah.
And it's actually very fast. Like they have you just kind of clicking keys to where you're not really thinking, so it's not a test where you're like, how do I beat this test? Like you're just associating.
Yeah.
And then at the end you get your results and you're like, wow, this actually is kind of true. So it's a pretty neat test, but it does take
I'll build it a bit sometimes.
It just makes you think too, right? Like one of them is about like disabilities. So it shows somebody like in a wheelchair with a broken leg. And you're like, obviously I'm going to associate it with that. I don't want to break my leg, but then it like goes through explanations at the end and like how that can be part of implicit bias that you don't even think about.
Another question. So like in like the late 1920s, 1930s, you kind of brought it up with like the eugenics movement in America then. And a lot of the things that were backing that up were at that time kind of considered to be like self-evidence or even like scientifically backed.
Yeah.
Certainly we've gone away with a lot of that stuff and advanced past that. But do you feel like there's stuff in this day and age that are kind of just implicitly taken as like, this is self-evident, it's just the way it is, that maybe we shouldn't be, or kind of what's your hot take on that?
Yes, no, I for sure think that's the case. And I think Mayo has more so ingrained in me to ask questions of why. We do all of these things just because. But if you sit down and think about it, why? I think Daniel is a good example of teaching us to ask why are we doing this and, really push the boundaries on that. I can't think of any like specific ones off the top of my head as far as like involvement of like race or ethnicity. But for sure, there's so many examples of doing all these things because that's what we've always done. But if you sit back and think about it, why? What's the studies behind it? Some of this stuff doesn't need to be done. That's a good point that you bring up.
Dr. Christian, thank you so much for taking on this delicate yet incredibly essential topic for us all to learn more about. You are an amazing clinician who has shown intelligence, integrity, and leadership in your short time here. And we at Mayo Clinic Emergency Medicine are all incredibly proud of you as you begin this next part of your life. To the Always On EM community, Alex and I hope that you found something from today's show that will stick with you and keep you thinking for the days to come. Please continue to pass on the word about our show to others, like and comment about the show when you have a chance or a moment, and find ways to be positive influences in your spaces. Don't forget to come back July 1 for the next release. We love you all for giving us your time and attention, and we wish you all the blessings that anyone can ever have. Thank you for listening.
The Always On EM Podcast.
Emergency Medicine Grand Rounds.